Today, I'm going to be talking to you about population versus personalized strategies for cardiovascular disease risk prevention. I've left some time at the end for questions, but I'm certainly happy to answer any questions as they come up. If there's virtual questions, someone will probably have to stop me if they want to answer during the talk. Otherwise, I'll just wait till the end. But just as a very brief kind of history of epidemiology and risk prediction, probably we can say that this field started back in the very late 1500s during the plague in London. They started this bills of mortality, and this was kind of our first data set where they were recording deaths due to plague in London. About 30 or 40 years later, they updated that and started recording cause of death for any type of death. And that's probably, like I said, our first database. And really, having a database is, a key essential part of epidemiology and risk prediction. The first person probably recognized as an epidemiologist was a man named John Geraint. He came up with this idea of a life table, so trying to predict the probability of survival to any given age. And that's kind of, I think, where the idea of risk prediction, started in the very first place, very, very long time ago. A lot of work in this field was actually done by the life insurance industry because they had a very vested interest to try to figure out which patients were high risk or low risk. James Dodson came up with this idea of statistically offset premium. So basically charging people who are higher risk more money for their life insurance compared to an average risk person. He tried to start a company with that, but was unsuccessful. One of his colleagues, Edward Rowe Morse, started the Equitable Life Insurance Society. And that was really the first life insurance company where they would try to estimate your risk and then charge your premium based on what your risk for mortality was. And he was, given the term of actuary, and probably the first person in that field to kind of think about risk from that perspective. So then all the way in the early 1900s, again, life insurance people were still very interested in this. Northwest Mutual started recommending that you measure blood pressure for their life insurance examiners. And a Northwest Mutual employee by the name of J.W. Fisher published this very important paper in JAMA in 1914, where he looked at systolic blood pressure, and he said a systolic blood pressure of 161 or higher, that those patients had about a twofold increased risk for mortality compared to patients with a lower blood pressure. This is probably our first academic research paper showing a risk marker and linking it to death or a CVD outcome here. So if we fast forward to the late 1960s, William Cannell worked at the Framingham Heart Study. And he came up with it, really what is the first kind of cardiovascular disease risk score. There are multiple iterations that became known as the Framingham risk score, which you're probably familiar with, but this was really the very first iteration of it back in the late 1960s. And if you look at the things that are listed here, they're pretty familiar to what we use in our current risk scores. Not all the same, but a lot of similarities. So we see age, total cholesterol, systolic blood pressure, cigarette smoking. He also included relative weight. BMI is now included in the most recent risk score, hemoglobin, and a yes, no if someone had an EKG abnormality. But this was really our first kind of objective statistical risk score to try to identify patients that were higher or lower risk for cardiovascular disease. Another leader in the field was a man by the name of Frederick Epstein. And he published a couple of really important papers, but this was a paper the same year as the first Framingham risk score came out, and he talked about these ideas of sensitivity and specificity, which I think are very common to us nowadays, but were kind of novel topics back then. Absolute versus relative risk, again, very important when we're thinking about individualized risk prediction versus population level risk prediction. And in this paper, he wrote that now we kind of have the opportunity to really hone in and individualize risk prediction rather than kind of just using our clinical gestalt when we see a patient and try to figure out their risk. So he published another very important paper a couple years later. And, this really talked a lot about this idea of individual population risk, individual treatment, and thinking more on a global or population level. If you look at the graph on the left, he termed these conditional, desirable, and essential, but I think we would call these, low, average, and high for the individual risk factors. And thinking about, on an individual level, which patients should we think about treating or classifying as high risk based on these risk factors. But then if we look on the right here from a population level, instead of picking certain parts of the bell curve, the idea is that if we move the entire bell curve, even just a little bit to the left, on a population level, we can actually have very large population reduction in cardiovascular disease and mortality, but two very different approaches to thinking about how we predict risk and how we treat individual patients versus thinking about treating on a more population level. So Jeffrey Rose was another leader who worked in London. And, this is about 15 years or so since the first Framingham risk score came out. And, he's still talking here, in medicine terms, 10 years is a pretty short amount of time, but he's kind of already lamenting the fact here that doctors are still really focused on treating sick patients and really advocating for the fact that we should be trying to prevent disease as one of our key goals of being a doctor, and not just waiting until a patient develops a disease and treating that disease once it's already happened. And so I think a really important thing that he pointed out in this paper, so if we look on the y-axis here, this is looking at deaths from cardiovascular disease, and on the bottom here is the total cholesterol. So the red arrow is showing that as your total cholesterol goes up, the event rate for cardiovascular disease increases. Even in the early 1980s, this was very well known. So that really is not unique. But I think the important thing that he pointed out here is if we look at these bar graphs, these is the prevalence of people that have coronary heart disease, that if we look at these people with the very high cholesterol, the very high risk, but they actually only make up a pretty small percentage of the total amount of people that are having a coronary heart disease event. So, focusing on one specific risk factor can definitely help on an individual level, but maybe on a population level, we're missing a lot of opportunities to treat here. And I think, again, really thinking about these different ideas of population versus individual risk prediction. So to bring it up to much more modern times, the most recent risk equation recommended by the ACC and AHA is the pooled cohort equation, which was published in 2013. This was very similar to the Framingham risk score. If you look at these things on the right in the table here, we see a lot of the same things that were in the very original risk score from the 1960s. And even in the more updated Framingham risk score from the 1990s, these are all pretty much the same things here. So again, using traditional risk factors, main differences with the pooled cohort equation are that, the Framingham population is based in Massachusetts. It's a predominantly white, kind of blue collar area. So it's not really generalizable to the entire United States. So in the 2013 equation, they included a couple of different cohorts to try to make this a little bit more generalizable to the entire United States population. And they also expanded the age range a little bit to be kind of from the age of 40 to 79 years old to encompass a much larger proportion of the US population. But, there's still, I think, significant drawbacks here. So there are a couple of things I want to point out. I think one important thing, and, I'm going to talk about the pooled cohort equation here, but these really apply to any risk score, whether we're talking about this one, the European, it's called SCORE, risk score, the very newest, like PREVENT equation, which I'll mention briefly in a little bit. But age is very heavily weighted risk factor in these risk scores. So if we look at older persons, nearly all of older persons are going to be classified into at least that intermediate risk where the guidelines would recommend considering starting statin therapy and preventive therapy. So just as an example here, I put these numbers in. This is a 65-year-old man. His LDL is 99, so very good. His triglycerides are normal. His systolic blood pressure is pretty good, 125. And he doesn't have diabetes or hypertension or smoking. But even despite having a very good risk factor profile, because of his age, he gets a score of 8.8%. Anything above 7.5% is considered intermediate risk, and the guidelines would recommend considering statin therapy. But I think we could say, looking at this risk factor profile, is that really an accurate representation of this person? On the flip side, if we look at younger persons, again, because age is such a heavily weighted risk factor, it's very difficult for a young person to get classified as even having an intermediate risk. So this is a 40-year-old man. His risk factor profile is much different. He has an LDL of 145, elevated triglycerides, low HDL. So, that would suggest kind of a metabolic syndrome or prediabetes type picture. His blood pressure is elevated, but despite a much higher risk factor profile, he only gets a score of 2.2%, which puts him in the low risk category. So again, here, this is really a big limitation for the extremes of age, and I think speaks to the fact that we really need to think about ways to better personalize risk scores. because, you know, on a population level, this works reasonably well for middle-aged persons, but, you know, we see a lot of patients that aren't middle-aged in our clinics. So I just have one slide here about the prevent equation, because like I said, all the things I'm going to talk about today pertain to whatever kind of risk score we're talking about. But this is the most recent risk score that just came out by the ACC-AHA. One of my colleagues at Hopkins, Chadi and Dumley, was the lead author on this paper. So this paper incorporates a couple of, I think, important ideas in terms of the CKM, or kidney-cardiometabolic idea. It includes a couple of additional risk factors. In addition to myocardial infarction and stroke, it also includes heart failure as one of the outcomes here. So we had a combined outcome of cardiovascular disease. And we know that heart failure is a growing problem in the United States. So I think that's definitely an important addition. But if we look at how it compares to the pooled cohort equation in the paper that was, published by the PREVENT authors, they mentioned that this change in the C statistic was one way we can look at improvement in classification. Was pretty low. It was 0.005 for women and 0.01 for men. So despite adding in, heart failure and a couple of additional risk factors, really the risk score is not actually improving our prediction that much. And this was actually a paper that just came out earlier this week in JAMA, where they compared the pooled cohort equation and the PREVENT equations. I think the two main things I want to point out is if you look at them, there's a lot of overlap between these two bar graphs. So again, speaking to the fact that despite these improvements in different risk factors and incorporating a larger number of people in the risk score to derive the risk score, that the scores are pretty similar, but particularly if you look at men, it's generally giving lower risk estimates, which we have to look at this a little bit further, but could be problematic because that, in this paper, the authors posit that that may lead to a lower prescription of statins, and they have an estimate that there may be a lot of increased risk of myocardial infarction due to this. There are a couple of editorials based on this paper. I think the important point here was that they're saying that maybe our risk estimates where we're recommending statins may have to change based on this PREVENT score, which I think makes a lot of sense. But also from a clinician standpoint, it's kind of confusing because we've now become accustomed to these kind of 7.5 to 20% as intermediate group. And we have a new risk score, which maybe doesn't actually improve risk prediction that much. And now we're having to kind of redefine what we consider as our low, intermediate, and high risk groups. And I think the overall idea of this is very good, but in practice, I think it may potentially lead to confusion and may not actually improve our risk prediction and improve allocation of preventive therapies. And really, when we're thinking about all of these risk prediction ideas, our goal is to identify high and low risk patients so we can prescribe medications to the high risk patients to reduce the risk of having an event, but also for the lower risk patients, we can reassure them and tell them that maybe they don't need to be on a medication because the risk is low. So the guidelines definitely do recognize the limitations of these risk scores. And the main thing that I want to point out here is that they recommend a couple of different things we can consider for refining our risk. So when we get that initial 10-year risk score, there's a couple of different things you can think about doing. One of the things they recommend is the coronary artery calcium score. I'm going to focus on talking to you about that today because I think that's really the thing that is really going to give us the most personalized or individualized risk prediction for patients. The other things that include in here, I think, are helpful to think about, but when we look at them in other studies, they don't really meaningfully change the risk prediction that much. So what did the guidelines recommend for coronary artery calcium scoring? I think important to mention that this is a measure of subclinical coronary atherosclerosis of calcified plaque. You can see here on this figure on the right, the person on the top left corner has a score of 0. They have no calcified plaque in the coronary arteries. The top right corner has a mild amount, a moderate amount, and then a severe amount. And I'll go through the gradation system here, but we'll get a number associated with that will help us put it into a mild, moderate, or high risk category. But what the guidelines really recommend is that, especially for those intermediate risk patients, which are going to be the 5 to 19% 10-year risk patients, that if there's uncertainty about that risk, that we can think about doing a coronary artery calcium score to better refine the risk, or they also talk about using it as a tiebreaker for someone that you may be on the fence about it. Another important use for this is maybe in someone you've identified as being high risk, but is concerned about starting a statin for a variety of different reasons. So we can think about doing this If they have a high score, then that might be a reason to, further kind of coach them or give them some additional information about the potential benefits to initiate statin therapy. For someone that may have already tried statin therapy and had side effects, maybe to retry a different statin therapy or try it at lower dose, or to intensify statin therapy for someone that you find out maybe is actually higher risk than you initially thought based on the 10-year risk score. So a couple of important things I wanted to point out about the CT scan itself. It's a non-contrast CT scan of the chest, so you don't need IV. There's no IV contrast. Unlike a coronary CT, you don't need to give any heart rate medication. So really, from a patient perspective, you go to the CT scanner, they're going to put on 3 EKG pads, and that's really like the extent of what we need to do. The scan itself, only takes a fraction of a second, and probably be on the actual CT table for kind of in the range of like 5 to 10 minutes while they get everything set up. So it's a pretty short scan. And I think it's pretty realistic, from when you walk in, kind of check in to get your scan done till when you walk out the door, probably less than an hour, which is pretty fast. In general, it's pretty inexpensive. So it's on the range of kind of $75 to $100. So again, even compared to other CT scans or MRIs, much less expensive. And the radiation dose is pretty low, so it's about 1 millisievert. So for comparison, that's similar to like bilateral mammography. Just living on planet Earth at Washington, D.C. sea level, you get about 3 millisieverts a year. If you live in a higher altitude area like Denver, you're going to get closer to like 5 or 6 millisieverts a year. So this is a pretty small amount of radiation. And as I'll show you, this is really something that for most patients we're going to recommend as a one-time test as opposed to being an annual test. Or maybe something they get done every 5 to 10 years, depending on their risk profile. The other, I think, really important point here is that this is, simple to perform in terms of, like I mentioned, from a patient perspective, there's not much they have to do, but also we don't need to use like a high-tech CT scanner. And I think that's really an important advantage. We usually think about low technology being not as good, high technology being better. But here, the low technology of Aspect makes it very accessible because this can really be done on pretty much any CT scanner. But also, like I mentioned, because you're getting a numbered score, it's very easy to interpret. So as I was mentioning with the PREVENT scores, we may have to change our thresholds for what we consider low, moderate risk. And that can be confusing to patients and clinicians and kind of hard to keep up with what are the current cut points. For a coronary artery calcium score, if you get a score of 0, that's ideal and low risk. And then any score above that in kind of a stepwise fashion, there's an increased risk. And, don't see that that's going to change over time. So 20 years from now, a score of 0 is still going to be a normal low risk score. And that makes it very simple because you don't have to tell a patient, okay, your LDL is 110. That might be a little bit high. It might be normal. We can just say 0, that's normal. And it's very simple to understand. So I just go very briefly about how we measure it. And this is all done by the computer. So as a clinician, as a radiologist, cardiologist, all you're doing on the CT scan is identifying these plaques. The computer is doing all of the measuring of the area and density and all the math for you. But the way the score works is each coronary plaque that we identify, it's going to measure the area of the plaque, and then it's going to give you a density weighting factor. The higher the density weighting factor, you're going to, higher Hounsfield units, you're going to get higher density weighting factors, you can see here. And then after you've identified all the plaques, the computer software will add all those up and give you a total coronary artery calcium score. So just as an example here, this is a plaque that looks like it's probably in the proximal LAD. When we click on it, the computer is automatically going to measure it an area of 15 millimeters. It's a dense plaque, so it gets a density weighting factor of score of 4. And then we just multiply 15 by 4, and that tells us for that one specific plaque in this plane, we're going to get a coronary artery calcium score of 60. And like I said, the computer will do all of this work for you. So our job is just to identify these plaques, and the computer will do all the I don't know if this is necessarily hard math, but do all the math for you. So it makes it pretty easy. So this is data from multi-ethnic study of atherosclerosis, which probably is our best data set for research on coronary artery calcium, but there's lots of other databases showing similar results. And when we look here on the top in blue is a coronary artery calcium score of 0. And as we go down, these are higher coronary artery calcium scores. And you can see that, with higher scores, you have a very nice separation of the curves here and really helping us to delineate risk in a stepwise manner. One important point that I want to make here, this data is out to 15 years, so pretty long-term follow-up. But if we look, even in the just first year or so, we can see even within a year or so that already these curves are starting to separate out. So, this is giving us really good information for 10-year risk prediction, which is what we kind of think about when we're thinking about medication allocation. But even in the short term, it's actually giving us short-term information as well about patients that are high risk versus low risk. The other thing that I want to point out here is if you look at this coronary artery calcium score of 0, again, this is 15-year follow-up, so pretty long-term follow-up from a risk prediction standpoint. These patients are very low risk. So over 15 years of follow-up, these patients have a coronary artery calcium score of 0, have an excellent prognosis. On the range of, less than 5% of these patients have developed coronary heart disease. And that's really one of the very unique things about coronary artery calcium scoring. One of the reasons that it really helps us to refine risk prediction so much is that, like I was mentioning before, it's can be a little bit tricky and sometimes over time change what we define as a normal risk factor, whether it's normal blood pressure or normal cholesterol. But even if we agree on what a normal traditional risk factor is, just because you have a normal blood pressure, we don't know anything about your cholesterol, your A1C, or other risk factors. And so, just by that alone, it doesn't tell us, for sure that you're low risk or not. But with a coronary artery calcium score of 0, because we're actually measuring the amount of atherosclerosis or disease that you have in the coronary arteries, regardless of your risk factor profile, we can say that you're at low risk. And I'll show you a couple of slides here to support that. One of the other really important points I wanted to make from a clinical perspective is that because we're doing this as a non-contrast CT, we can't measure percent narrowing. But really, from a risk prediction standpoint, that's not something we should worry too much about. One important thing here is that the guidelines recommend that this kind of a test should be done among asymptomatic patients. So we're really thinking about, patients that we're trying to refine risk, not patients that are coming in complaining of symptoms. And even, when we look at these patients, so on the bottom here, this is a table of patients who had a coronary artery calcium score and a nuclear stress test done at the same time. These were asymptomatic patients as a part of a research study. And what we see here is that even if we look in the very highest risk group, so the coronary artery calcium score of above 400, only about 10% of these asymptomatic patients had an abnormal nuclear stress test. And if we think about that a little bit more, we know that an abnormal nuclear stress test has about a 50-50 chance that that person actually has obstructive coronary artery disease if you take them to the cath lab. So really, we can probably cut this number in half and say about 5% of patients in that above 400 group actually have obstructive coronary artery disease. And we know that most of those patients are actually going to be at much higher scores than 400, really more like the patients that are closer to that 1,000 or above range. So, again, when we're thinking about this in asymptomatic patients, we really should be focusing on risk prediction. And the other reason this is important is that we don't want to be sending these asymptomatic patients for stress testing or other procedures, because we know that when we think about coronary artery stenosis, we should really be thinking of that primarily from a symptom standpoint. And when we're thinking about risk prediction, we really want to know somebody's plaque burden. So if somebody's asymptomatic, there's really not any specific reason we should be sending in for stress testing or other things to pick up for coronary artery stenosis. So I'm just going to show you one or two slides here. So trying to bring these two ideas of traditional risk factors and traditional risk scores together with coronary artery calcium scoring, if these are telling us the same information, then there's really no benefit to doing them because we can just pick one or the other. But there's actually a lot of heterogeneity or differences between the same people that we do traditional risk factor profiling on and these patients that we do imaging on with coronary artery calcium scoring. And I'll show you just a couple of examples here to highlight that point. But this is data from the Coronary Artery Calcium Consortium, which is about 70,000 patients who had a clinical coronary artery calcium scan performed. And these were asymptomatic patients who are largely middle-aged. But when we look at these patients who have diabetes, this is a group that the ACC/AHA recommend if you have diabetes, you should be on a statin regardless of what your risk factor profile is. But about almost 40% of these patients actually had no atherosclerosis or a coronary artery calcium score of 0. Which I think is a little bit surprising on face value. But we actually see the same thing when we look at other individual risk profiles. So if we look at hyperlipidemia, this was a paper from MESA by one of my colleagues, Seth Martin. So here he used total cholesterol to HDL ratio, which we generally think is a little bit better than LDL for risk prediction, but basically showing us the same general information. The graph on the far left is people who had the lowest total cholesterol to HDL ratio, so the lowest atherogenic lipid burden. The people on the right who had the highest atherogenic lipid burden. But again, we see like the very similar thing here. These people have a high atherogenic lipid burden, but again, about 40% of these patients actually still have a coronary artery calcium score of 0. So a lot of discrepancy here between their traditional risk factor profile and whether or not they have calcified atherosclerosis or kind of the disease in place already. And that has important implications for when we think about their risk, because if they have a high cholesterol and a calcium score of 0, but still have a lot of events, then again, we're not doing much good here by finding risk. So in this paper, and there's many other papers showing the same thing with other high-risk groups, but they went ahead and looked at these patients where they divided them up by their lipid profile and their coronary artery calcium score and looked at these CVD events. So if we look at this back row here in the red bars, these are patients who had a coronary artery calcium score of above 100, which we consider 100 to 200 kind of in the moderate range. So, moderate to severe coronary artery calcification. And we see that for the patients that had a low LDL, intermediate, or high LDL, doesn't really matter if they had a coronary artery calcium score of 100 or higher, that they have a much, much higher CVD event rate. On the flip side, if we look at these patients in the yellow here who have a coronary artery calcium score of 0, again, we see the same thing, but opposite, or the inverse relationship. Doesn't matter if they have a low LDL or a high LDL. If they have a coronary artery calcium score of 0, their risk of coronary heart disease is very low over time. So again, really showing us that if we want to predict somebody's risk here, we should really be thinking about their burden of atherosclerosis, which we can measure by coronary artery calcium, and not so much their risk factors. So that data was showing individual risk factors, diabetes, hyperlipidemia, but we know that, in the risk scores, we include multiple different traditional risk factors. So this is a paper by Kerm this year where we wanted to take the pooled cohort equations, which incorporate all these risk scores, our kind of best statistical techniques to predict somebody's risk, and then compare that against coronary artery calcium scoring to see if there truly was a benefit here in terms of stratifying patients and identifying high and low risk patients. So on the far left is going to be the patients that were in the recommended statin group. So those are going to be kind of the 4 categories that the ACC/AHA recommends. So that's going to be people with an LDL of greater than 190, who have diabetes, and ASCVD risk either in the intermediate or the high risk group. And the people on the far right are going to be the very lowest group, which are going to be less than 5% estimated risk. And the blue here is the coronary artery calcium score of 0. So we do see that patients who have a lower risk factor profile, a much larger percentage of them do have a coronary artery calcium score of 0. But again, if we look at these patients who are in one of the 4 statin recommended groups, about 40% of these patients still actually have a coronary artery calcium score of 0. So again, a lot of discrepancy between using our risk factor tools and risk factor equations to identify high-risk patients, but then actually finding out that they don't really have atherosclerosis, at least calcified atherosclerosis yet. And so again, they looked at these by events. So these are patients that were low-risk individuals. So these are patients who are in that far right group who have a very low 5% risk. And what they found was that in the small percentage of those patients, so it's about 4%, so a pretty small group, but in those 4% of patients that were in low risk who had a coronary artery calcium score above 100, you can see they have a much higher risk of heart disease over the next 10 years of follow-up. So if we think about performing coronary artery calcium scoring in low-risk individuals, we're really trying to uncover high-risk patients. So we might think about patients who have a very strong family history of heart disease, who maybe don't necessarily meet the high-risk group. Like I showed you, that younger person with a pretty high risk factor profile for their age, but not meeting criteria by the ASCVD risk equation. So, we might use one of these risk-enhancing factors, maybe a high elevated lipoprotein A. And then if we do the coronary artery calcium score, we can uncover these individuals who are actually at high risk. On the flip side, if we think about these patients who are in one of these 4 statin recommended groups, we see the same thing I showed you with the other information for the individual risk factors, that the patients who have a coronary artery calcium score of 0, this is 10-year follow-up, less than 5% of those patients are developing coronary heart disease, even though they're in one of the 4 statin recommended groups. And then we know with higher coronary artery calcium scores, we see a higher event rate for coronary heart disease. So for these patients, especially in the intermediate risk group, performing a coronary artery calcium score, we can think about uncovering or de-risking those patients who are actually at low risk, who might otherwise be classified as intermediate or high risk. This was a paper I just wanted to show here because I think we've been talking about measuring coronary artery calcium score at one point in time and then following their risk over time, but not kind of what happens to the coronary arteries during that follow-up period. So we wanted to look at patients who had a follow-up scan 10 years later in the MESA study. And again, this number of 40% keeps coming up. But if you look on the far left here, we see that if we take all 4 of the statin benefit groups together, after 10 years of follow-up, those patients who are in a high-risk group that has score of 0, about 40% of those patients still have a coronary artery calcium score of 0 or have no identifiable calcified atherosclerosis. So it's a pretty unique group of patients that we traditionally classified as high risk, but actually have healthy arterial aging. And I think this is a unique phenotype that we're trying to study more to try to figure out, when we think about risk factors, we're identifying high risk groups, but we also need to think about risk factors that can identify lower risk groups as well. When we look at their event rate, these curves on the face of it look different, but statistically, there's no statistically significant difference in the event rate for the patients that continued to have a calcium score of 0 10 years later versus those who had an incident coronary artery calcium score above 0. Even in the group that had incident coronary artery calcification, still only about 5% of those patients developed a CVD event over time. And if we look halfway through that follow-up time, so at 5 years, the patients that went from a score of 0 to a positive score, the median score was only 30, which would be on the low end of the low risk group. So if we think about doing follow-up scans, and I'll go through the kind of timing of it, but somewhere in the 3 to 7 year range based on their risk profile, we can try to pick up these patients very early in the atherosclerotic process before they've had an event and kind of at the ideal time for thinking about starting preventive therapies rather than waiting until they've already had an event or have a very high coronary artery calcium score. The other thing that I wanted to mention, I think in general, we really want to focus on the absolute Eggerson score, which is what I've been talking about up to now. But if you get a formal coronary artery calcium score, you will also get a percentile. So I just wanted to talk about that very briefly because I think that has important implications, especially for younger patients. So for patients that you might see in like med peds clinic, if you get it, especially in someone who's under the age of 45, that's something that's going to be very important to look at. So again, going back to this example, this is a young man. He has a coronary artery calcium score of 5. Like I said, 1 to 99 is considered mild. So we might say, this is a pretty low score. 0 is ideal. You're at 5. Maybe we shouldn't worry too much about that. But if we look at their age, sex, and race ethnicity percentile, that actually puts them in a very high percentile here. So 79th percentile, even though they have only a score of 5. So that tells us that their risk is much, much higher than we might have otherwise anticipated over 10 years, but particularly if you think about this person's lifetime risk, they're only 45 years old, 20 years from now, 30 years from now, their risk of having a coronary artery disease event is extremely high if we don't do anything to treat them. And based on this percentile score being above 75, the ACC/AHA guidelines would recommend that they start at least a moderate to high intensity statin therapy, which is the same as what we'd recommend for someone who has a score above 100, versus if we just went off the score of in the 1 to 99 range, they recommend considering starting moderate intensity statin therapy. So I think this is, again, especially for younger patients, something that's very important to look at so that we don't kind of blow off these young patients with low scores as saying, nothing too much to worry about here. So what are the actual guideline recommendations? Well, these are from the 2018 cholesterol and 2019 primary prevention guidelines. So coronary artery calcium scoring gets a level 2A recommendation. The primary group, like I mentioned, that they're going to recommend this risk scoring is for the intermediate risk patients who are in that 5 to less than 20% risk group. And what they recommend is that if you have a coronary artery calcium score of 0, that statin therapy is not recommended because you're low risk, unless you have diabetes, a strong family history of heart disease, you're a smoker, or have an LDL-C of greater than 190, which would put you in that kind of familial hypercholesterolemia group. Like I mentioned, if you have a score of 1 to 99, which we consider to be a mild score, They have this wording that favors at least moderate statin therapy. So kind of, the clinician-patient discussion about whether or not to start it. All these recommendations are going to be based on shared decision-making, but this is a much kind of softer recommendation from the guidelines to kind of think about starting statin therapy. Personally, I think, with rare exceptions, I think it definitely would make a lot of sense to start at least moderate statin therapy for these patients. And then if you have a score of above 100 or above the 75th percentile for your age, then they recommend that you should start at least moderate or high intensity statin therapy. So a little bit stronger recommendation, and also higher intensity statin therapy that they recommend for those scores above 100. But we know that, risk is on a continuum, whether we're measuring blood pressure, cholesterol, and also coronary artery calcification. So it's nice to put things into boxes or groups or silos because that makes it easier for us to remember. But, risk is over a continuum. And when we look here, we see that as the coronary artery calcium score goes up, there's a pretty nice increase in risk, or maybe not a nice increase in risk, but there's a statistically, easy to follow increase in risk here. But I wanted to point out, I think, important cut points to think about. So, what I've talked about now is kind of the 100 to 299 being moderate, above 300 being severe. But, kind of what does really severe mean? So this was, again, a study from the MESA study. And the line on the left, that red line, is right at about 350. So a coronary artery calcium score just a little bit above 300. And what they found was that patients who are asymptomatic, their risk or event rate for having a cardiovascular disease event was actually the same as compared to patients that had a prior cardiovascular disease event. And that's really important from a risk standpoint, and particularly a medication allocation standpoint, because a lot of preventive medications that we think about using, and a lot of the goals that we think about in the guidelines are prescribed by primary prevention versus secondary prevention. But I think that we're seeing that is, again, something that's easy to classify or categorize, but something that we're seeing over time, that there's actually overlap between primary and secondary prevention patients here. So we're seeing that primary prevention patients who've never had an event, if they have a coronary artery calcium score of about 350 or higher, that their risk is actually the same as someone who's already had a cardiovascular disease event. So I think that is really important when you're talking to patients to kind of put that into perspective for what it means, not because we want to kind of scare patients or, make them nervous, but just say that, this is really important. Then we really need to focus on this and make sure we do a good job. The line on the right here is at a coronary artery calcium score of 1,000. And you see the little box just, a little bit to the left, which is probably just above 900. That was the event rate from the Fourier trial. So that was a PCSK9 inhibitor trial of very high risk secondary prevention patients. So, another, I think, easy kind of number to remember is that 1,000 number, that patients that are even approaching that number are at a very, very high risk, similar to high risk secondary prevention patients. So that study was from a couple of years ago. There's another study that came out this year by Matt Budoff using a different database, but again, showing the same thing here. So I just, again, want to make the point that he showed that for these primary prevention patients who had a coronary artery calcium score of 300 in the purple, that line almost exactly overlies the yellow line, which are patients that have already had a prior cardiovascular disease event. So we have information from a couple of different databases showing that this 300 cut point is a really important cut point to think about, because those patients are in that same risk group as secondary prevention patients. And again, we want to think about more strict control of their risk factors and potentially different medications that we may want to prescribe for those patients. So I'm just showing this here. This is just one way we can think about doing it. I'm not going to go through all of it in detail, but I just wanted to make a couple of points here. So if we look at the green box on the far left, that's a coronary artery calcium score of 0. So I just wanted to come back to the idea of what should we do if someone has a coronary artery calcium score of 0. As I mentioned before, we can think about getting a repeat scan for them. So these numbers, or the time frame here between scans, is from the MESA study. From one of my colleagues, Mike Balaha, published a paper on this. And what they recommended was that if you're in a high ASCVD risk, so ASCVD above 20% for your 10-year risk, or you have diabetes, you might want to think about repeating the score in 3 years. If you're in that intermediate risk group of the 5 to 19%, you might want to think about the 3 to 5 year range. And if you're in the low risk group, you might want to think about a 5 to 7 year range for repeating it. And if you follow this general criteria or timeline they've recommended, there's about a 25% chance that you go from a 0 score to a positive score. So, talking with your patients and depending on their risk factor profile, you may be able to do a little bit longer time between scans, depending on how certain they want to be. But I think this is a rough, guideline that's helpful to think about for these patients of when we should think about potentially rescanning them to try to see if they've converted from a 0 score to a positive score. The other important point that I wanted to make here is that the guidelines really focus on statin therapy, particularly the cholesterol guidelines, obviously. But we know there's a bunch of good studies showing that if you have a coronary artery calcium score above 100, then we should maybe think about aspirin therapy. And like I was just showing you, above 300, I think that'd be a much stronger recommendation. It's still strongly recommended as a level 1 recommendation for secondary prevention patients. Really, the main reason we've moved away from recommending it for primary prevention is the small risk of bleeding. So in patients that you see that have a high calcium score of at least 100, I'd say particularly those patients who have a score of 300 or higher, if they're at low bleeding risk, and I think, a baby aspirin is something that would be worth considering for those patients. But we also have a lot of newer medications over the last 10 years. So everyone knows about GLP-1 receptor agonists, that they can reduce your risk of coronary heart disease in addition to helping with diabetes and obesity. So we have a paper that hopefully will be coming out in the near future showing, again, using your coronary artery calcium score to risk stratify that those higher risk patients, that's something we want to think about them. We know from the SELECT trial that even if you don't have diabetes, but you're obese and high risk, that GLP-1s can reduce your risk. The insurance companies haven't caught up to that yet, but I think over the next few years, we'll see that they're catching up and improving that. And then also for these patients that are very high risk, so here, the recommendation was above 1,000, and that's based on an ACC guideline for non-statin therapy that came out about 2 years ago. But I think even 1,000 is probably a little bit of a high threshold. But thinking about, an LDL goal of less than 70, again, in that secondary prevention category, or even less than 55 based on the National Lipid Association guidelines, or the European guidelines recommend even that more strict recommendation. So, if your patients who are in this high risk coronary artery calcium score or high-risk group, thinking about ezetimibe, bempedoic acid, or PCSK9 inhibitors to really make sure that we do a good job controlling their LDL cholesterol and getting it below 70. So, we can use this. I think the idea here is that we're predicting somebody's risk, and then based on that, then we can really focus in on their particular treatment targets. And I always like to kind of put things in order as best as I can, because now we have a lot of different medications we can prescribe. So kind of identifying what of their traditional risk factors are most poorly controlled and kind of going in order of those. And certainly we're going to want to cover the basics, but I think that can also help us with figuring out our goals for treatment and which medications we may want to use. So the last thing that I just wanted to mention here was that I've been talking about formal coronary artery calcium scoring, where we're going to put in an order, send a patient to get the CT scan done. But we know that a lot of people get a CT scan of the chest for non-cardiac indications. And there's been a number of studies, this is just one example here, showing that we can use these non-cardiac CT scans, particularly the non-contrasted scans, to measure coronary artery calcium. And that gives us a very similar number as if we sent someone for a formal risk score. And this is really important because this is really free information. If you look here in the United States, on average, maybe about 1 million or so patients are getting a formal coronary artery calcium score per year. But almost 20 million patients a year are getting a non-contrast CT scan of the chest for a non-cardiac indication. So really, if we're thinking about implementing the use of coronary artery calcium, it's helpful to focus on sending patients for a formal scan. But really, I think a lot of our focus should be on using these scans that have already been performed. And this is free information. So even though it only costs $75, if the scan's already been done, there's really not much need to necessarily send the patient back for another formal scan. And as I showed you in those images, it's pretty easy to identify coronary artery calcification. So there's a number of artificial intelligence software companies that have developed programs, and a number of institutions across the US have already adopted these. But even just looking at it on a visual basis and grading it mild, moderate, severe, or even just grading a yes, no, you can really significantly improve how you classify a patient's risk. And I think the other thing, and I'll show you an example here in a second, but we hear a lot about artificial intelligence, particularly medicine, but most of the things we hear about are things that are coming in the future, or wouldn't this be great if this pans out? But this artificial intelligence for coronary artery calcium scoring is already FDA approved, already in use clinically at many institutions across the United States. So this is an example of artificial intelligence that we can already use and benefit from. So just as an example here, this was the Notify-1 study that was done at Stanford. They used one of these commercially available artificial intelligence software programs to look at a non-cardiac CT chest to grade the degree of coronary artery calcification. And then what they did was half of the patients in that study, they sent the patient and their clinician information to say, you had this non-cardiac CT scan done. You have X amount of mild, moderate, severe coronary artery calcification. Based on that, here's what the ACC AHA guidelines recommend. And about 50% of those patients actually got started on statin therapy when they were given that information. The other half of the patients who they weren't told about the coronary artery calcium score results from their CT scan, even though they had coronary artery calcium present, you can see that on the order of maybe like 5% of those patients got started on statin therapy. So a very big difference here if we use this in terms of helping to appropriately allocate primary prevention medications. And then this is again just here showing this is true across all sorts of different groups in the study. So I wanted to kind of put this succinctly together, and I think Harvey Hecht really did a very nice job 20 years ago about this. So it's not to say that we shouldn't measure traditional risk factors. They're very important to measure and very important to know. But really, when we're thinking about predicting somebody's individual or personalized risk, we really want to be measuring their burden of atherosclerosis, and coronary artery calcium, I think, is really the best way for doing that. And then once we know that what their risk is, especially if they have a positive score, then we really want to think about the risk factors as these are treatment targets for ways that we can prescribe medications, prescribe diet, lifestyle to really help reduce their risk going forward. And that's really going to provide us our most personalized risk prediction versus if we're using traditional risk factors, that's really going to help us more on a population level, but not so much the patient who's sitting directly in front of us in clinic. It's not going to give us the personalized information that we really want for them in this current day and age. So just to summarize, risk factors work well on a population level for risk prediction, but much less well on an individual level. As I showed you, there's a lot of heterogeneity or discrepancy between traditional risk factor scores and whether or not somebody has atherosclerosis on the CT scan, particularly for those patients that are in the intermediate risk group. And particularly among younger and older patients, traditional risk factor scores work much less well than they do among middle-aged patients. So coronary artery calcium scoring is a simple, low technology, low tech cost. And we know that as your burden of coronary atherosclerosis increases, that your risk of cardiovascular disease increases in a stepwise manner. Conversely, and like I mentioned, I think one of the most powerful points of coronary artery calcium scoring is that if you have a score of 0, that we can say that you're at low risk over the next 10 years, regardless of your traditional risk factor profile. And I think that's very important personalized information we can give to our patients. And really thinking about individual risk factors, really we want to focus on those, not so much for individualized risk prediction, but really thinking about treatment targets once we identify somebody who's at increased risk, and then we need to do something about that.